Recording in progress.
Hello, hello, hello. Okay, that works. All right, it's time. Good morning, everyone. Again, I realize this is not optimal, but it's what we were asked to do. So far be it from me to tell the administration to go pound sand. So we're going to do class this way. When I walked to school today, it looked to me like we had less than an inch. And my daughter texted me last night. She lives in Ann Arbor. She thinks this whole thing is being hyped, but maybe by Thursday we'll have a lot more snow. I don't know. All I know is that they kept ratcheting down the expectations from 16 inches to 12 inches to 8 inches. Now I'm hearing it's more like 6. Western schools have canceled schools. Jackson County schools, as far as I know, have canceled schools. So everybody's canceling. Well, there you are. All right, so as I said, if you have a question, please use the text. Sometimes when I'm lecturing, I don't see the text adviso thing come up. There's normally a little flashing red box that says someone's put something in the text. I don't always see it. Otherwise, unmute yourself and ask a question. If you are just listening, please mute yourself to make sure we don't get feedback coming through microphones and things like that. Very good. If I need to use the Blackboard, I'm going to use my camera over here like this, which I'll just draw on that, and that'll be our Blackboard. All right, let's have a word of prayer, then let's begin. Lord, thank you for this snowy day. We pray for every student as they try to learn with Zoom. Please help them stay engaged. And even though this is not optimal, Lord, I just pray you'd really help us focus. Whatever it takes, coffee, caffeine, chocolate, whatever, help us to stay focused and be earnest. For you have given this opportunity to us to go to school, to earn an education. In Jesus' name, amen. Let's talk about pharmacodynamics. Remember, pharmacodynamics is what the drug does to you. All right, now the slides should move if I do that. If they don't, please say something. All right, nobody's saying anything. I'll assume the slides are moving. So drugs are going to address certain targets in the cell or outside cells. One of the biggest targets they address are receptors that are embedded in cell membranes. We're going to look at a group of drugs called the anticoagulants that will bind to and inhibit enzymes that are secreted outside cells. They will inhibit inhibit clotting factors that are secreted into the bloodstream by hepatocytes, by liver cells. Other cells will target molecules that are also soluble. Other drugs will enter cells and then will address targets inside cells, again, sometimes enzymes. Most drugs that we will look at will bind to receptors outside the cell. And usually there is a relationship between the dose of the cell, of the drug, the concentration of the drug, and its pharmacological effects. The interaction between the drug and its target is the reason the drug tends to be selective in its action. Drugs do not bind to tons and tons and tons and tons of targets. They will usually bind one target really well, another target less well, and then other targets hardly at all. They may bind to more than one target, or as the concentration goes up, they may then start to bind to other targets, which is why drugs will need to work within certain dosages. But the interaction with its target, with its receptor, is the reason for the drug's selectivity. The binding of the target, the receptor, is also the way the drug mediates its action. Now, if a drug binds to a target and elicits the typical biological response that you get when that receptor is activated, that molecule is called an agonist. So to illustrate what I mean by agonist, let's go to our makeshift blackboard here. So let's say we have a cell membrane here, and embedded within this cell membrane, let's say, is the receptor for the hormone epinephrine. So epinephrine, when it binds to this receptor, will elicit a biological response. And it depends on the tissue, it depends on the downstream targets. If it's a cardiac cell, then the heart will beat faster, the heart rate will increase. The blood pressure will also increase. In many blood vessels, you'll get vasoconstriction. That's going to be in peripheral blood vessels. Whereas your more systemic blood vessels, like those that feed muscles, will undergo vasodilation. Yeah. Now, what if instead of epinephrine, you were to take a molecule that's sometimes found in certain pre-workout formulations called ephedrine? Ephedrine, as it turns out, can also bind to this receptor and elicit the same response. Ephedrine, therefore, is an agonist for this epinephrine receptor. It binds to the receptor and it elicits the same response. So is pseudoephedrine, and pseudoephedrine is the material found in Sudafed, the decongestant. These are examples of agonists of this receptor. So these molecules still bind to the receptor, still elicit the response. They therefore are agonists. All right, I hope that is clear. So either the native molecule that binds the receptor, like epinephrine or like norepinephrine, those are agonists of beta 1, beta 2, alpha 1, alpha 2 receptors, or ephedrine or pseudoephedrine or isoproterenol or other drugs like that that will activate those receptors. They are agonists for those receptors. Now, this is an example of a so-called concentration effect curve. We can see here, as the concentration of the drug goes up, the response to the drug that you get increases. Notice that there comes a point where you can give more and more drug, but you don't get more of a response. So this type of curve is hyperbolic, and it gets to a point that is a so-called asymptote. This asymptote is the 100% biological effect line. Notice that this curve is not linear. Notice also that there's a concentration of the drug at which you get half the drug effect. That concentration is called the EC50, effective concentration 50. That's the concentration of the drug it takes to achieve half the biological response, whatever that biological response is. Maybe it's vasodilation, maybe it's vasoconstriction, maybe it's a heart rate going up, maybe it's a heart rate going down, maybe it's blood pressure going down, maybe it's increase in body temperature, decrease in body temperature, whatever. Whatever that response is, the amount of drug it takes gets half that maximum response. That's the EC50. Now, if we were to express this particular graph in terms of number of drug receptors bound, the graph would also look hyperbolic like this. But in this case, that concentration of the drug where half the receptors are bound is called the K sub D. K sub D. So K sub D ends up being a measure of the affinity of the drug for its receptor. The lower the KD, the higher the affinity of the drug for its receptor or for its target. Now, ED And KD are not the EC50, excuse me, and not KD are not the same thing. Why? The reason why, very simply, is that some cell types show a very robust effect, even though very small numbers of receptors are bound by the agonist. Other cell types will need lots of receptors to be occupied before you get a biological response. So because of that disparity between sensitivity of the cell, of the tissue, of the organ for the drug, KD is simply a biochemical measurement. The measurement of that concentration of the drug at which half the receptors or the targets are occupied, are bound. That doesn't mean you'll get half the biological response. It depends on the organ, the cells, the tissue. That's why they're not the same thing. One's a physiological response, the other is a biochemical measurement. Now you can measure KDs very effectively using a procedure called the scattering analysis. Here's how a scattering analysis essentially goes. You use this equation here. And what this equation is going to measure is an experiment you might do the following way. So let's say you take a cell type that you grow in culture, you express the receptor for that drug in those cells, you give the cells drug that's labeled with some sort of tag that you can detect. We used to do these experiments using radioactively labeled drug. We don't use radioactively labeled drug anymore. We use drugs that have a fluorescent tag on them or something like that. So you give certain concentrations of the drug to these cells, then you compete it with known concentrations of unlabeled drug. And so you're going to get numbers like concentration of the ligand. That's how much drug you put on there. There's free ligand and there's ligand that's bound to the receptor. And this is the maximum number of receptor sites. And so what you have here is a linear equation. You have an mx, y equals mx plus b type of equation. That's going to be the slope of your line. And if you do this experiment in this way, this ratio essentially will be y for the graph. You get a graph like this, and the slope is minus 1 over kd. Now, why am I torturing you with this? I'm torturing you with this because I want to show you that KDs will be reported in a good deal of the literature for drugs. Those KDs are very well understood. They're calculated to a high degree of precision. They're not guesses. So we know KDs for drugs. They're relatively easy to calculate. They're relatively easy to assess. They're assessed experimentally, and they're well understood. And if the drug has multiple targets, KDs for each of those targets are usually pretty well understood. Now, if the drug binds to the receptor and elicits a complete and full physiological response at high concentrations, it's called a full agonist, just like methadone here, a full agonist. Some drugs, however, bind to the receptor, and even at high concentrations, they don't elicit a full biological response. It has nothing to do with its affinity for the receptor. It just has to do with the fact when it binds a receptor, it doesn't activate the receptor completely. These types of drugs are called partial agonists. Partial agonists. Good example is buprenorphine. Buprenorphine is an opioid, and it's typically used in elderly patients who don't want to get a buzz off their opioid but still want pain relief. Also, they might be forgetful as to how much they took. So if they take a little too much, they're not going to get euphoria because it's a partial agonist. Buprenorphine is also used to help wean people off opioids, as is methadone. The difference is that methadone is only given in federally licensed clinics. And you give it intravenously, so patients leave the clinic with the methadone in their veins. They can't therefore divert the methadone. Buprenorphine, on the other hand, if physicians take a weekend course on its use to help wean people off opioids, people who have opioid use disorder, they themselves can prescribe buprenorphine for that purpose. Here's an example of a combination of a partial and a full agonist. And here we have the fraction of multiple response. And so if we mix our partial agonist with our complete agonist, our full agonist, this is a fraction of the maximum response. As the concentration of the partial agonist decreases, its response is going to tank. If, however, we mix it with a partial agonist, eventually we just get a partial response that stabilizes here as the concentration of the partial agonist increases and the concentration of the full agonist decreases. An antagonist binds to the target but elicits no response. Because it elicits no response, it gets in the way of any native agonist. These molecules antagonize the receptor, they antagonize the target. Competitive antagonists bind to the target, dissociate, bind to the target, dissociate, bind to the target, dissociate. Their effectiveness at inhibiting the target is dependent on their concentration. Irreversible antagonists bind to the target and form a covalent adduct with it. Because they form a covalent adduct with it, the receptor is irreversibly, the target or receptor is irreversibly inactivated. Now the cell has to remake new receptor. So this will tank the response, and the response will be decreased for a period of time. Aspirin, for example, is an irreversible antagonist of its target, the enzyme cyclooxygenase. Whereas other over-the-counter non-steroidal anti-inflammatory drugs like naproxen sodium, like ibuprofen, drugs like that, they're competitive agonists. So their mode of action is concentration dependent. And on this graph here, you'll notice there's this drug, naloxone. Naloxone is an opioid receptor antagonist. Naloxone goes by the trade name Narcan. Narcan is used to reverse opioid-induced comas or unconsciousness or something like that. Narcan comes as a nasal spray, and it's given by EMTs, firemen, police officers, and what have you, to help people gain consciousness if they stop breathing because of opioid overdose. It works very quickly. All right, now the drugs that we're going to look at, some of them are going to be steroids. Steroids are hydrophobic. Because they're hydrophobic, they can charge right through the membrane, uninhibited. They don't need to bind a receptor embedded in the cell membrane. the receptors that they bind are found inside the cell. Those receptors are direct transcription factors. So steroids will bind the receptor inside the cell, and they will elicit changes in gene expression. Therefore, they'll elicit the synthesis of new proteins, and steroid drugs in general tend to work very rapidly. Most of your other drugs will bind to receptors embedded in the cell membrane that will elicit some sort of change inside the cell. You'll induce some sort of second messenger, some sort of signal transduction pathway that may typically culminates in the production of a second messenger, like cyclic AMP, or the release of calcium, or cyclic GMP, or something like that. And that will elicit changes in cell behavior, and usually also elicits changes in gene expression. So drugs that affect these pathways will usually address the receptor. Most of the drugs that are going to affect signal transduction pathways will be your anti-cancer drugs. Other drugs, however, will affect the synthesis or breakdown of second messengers, as we will see. All right, before we talk about steroids, let me just pause right here, see if anyone has any questions, make sure we're all on the same page. All good so far? All right, then. Let's go ahead and continue. So steroids don't need to bind to membrane-bound receptors. They go straight into the cytoplasm. Most steroid receptors are found in the cytoplasm. There are a few steroid receptors that are found in the nucleus. The big one is thyroid hormone receptor. Thyroid hormone receptor is found in the nucleus. Virtually all the others are found in the cytoplasm. Once they bind their target being the steroid hormone, steroid drug, whatever, that complex now enters the nucleus and elicits changes in gene expression. This group of proteins that bind steroids, they're members of a large family of proteins called the steroid receptor superfamily. These proteins can bind DNA and regulate gene expression. However, they only do so when they're bound to their target. Again, the exception being the thyroid hormone receptor. The thyroid hormone receptor binds DNA without being bound to thyroid hormone. But when it binds thyroid hormone, it goes from being a repressor of gene expression to an activator of gene expression. Your cell surface receptors are embedded in the cell membrane. When they bind their agonist, they change conformation. That change in conformation elicits some sort of signaling cascade inside the cell. These pathways are called signal transduction pathways. These pathways are complicated. Now, last year I spent time going through many of these pathways. As I reconsidered this class, I discovered that going through those pathways really didn't benefit students that much. So I'm not going to go through the details of those pathways. I'll only talk about kind of the culmination of many of those pathways. So here are some of the pathways that are affected by many of the drugs that we will examine. The biggest one is the G protein coupled receptors. They activate a 3 subunit protein called the G protein inside the cell. And those G proteins, when they're activated, they will activate downstream targets. Many G protein coupled receptor pathways culminate in the synthesis of cyclic AMP. Others will elicit the decrease in the synthesis of cyclic AMP. A few others will cause the release of internal calcium stores. So these particular pathways, there are lots of ways that they can go. The triphosphoinositol calcium pathway causes the release of internal calcium stores and the activation of something called protein kinase C. That pathway is quite important for several different biological phenomena. The receptor tyrosine kinase pathway culminates in the generation of phosphorylated proteins. In particular, proteins that have a phosphate group attached to the amino acid tyrosine. And phosphotyrosine is a very powerful signaler inside cells. The receptor tyrosine kinase pathway is used by growth factors. The cytokine pathway is used in the immune system. It's also used by the signaling molecule erythropoietin, which is used to signal to your body to make more red blood cells. This is very similar to the receptor tyrosine kinase pathway, but this particular pathway generates phosphorylated transcription factors that enter the nucleus and elicit changes in gene expression. The MAP kinase pathway will cause changes in gene expression as well. This is necessary for cell growth and cell survival. And then the beta transforming growth factor, transforming growth factor beta or boron morphogen protein pathway utilizes the phosphorylation of serine and threonine amino acids. And this is used by several pathways that are important in wound healing and what have you. So these are all pathways that are affected by many of the drugs that we will look at. And many of these pathways cause the synthesis of second messengers. What are second messengers? So when you activate a pathway, you might activate one or a few receptors. Those one or few receptors, however, cause the synthesis of thousands of these second messengers. So second messenger synthesis is an amplification step. These second messengers are very, very powerful signaling molecules inside cells. And they include cyclic AMP, cyclic GMP, calcium, and then phosphorylated proteins that have either phosphorylated tyrosine, phosphotyrosine, or phosphorylated serine or threonine, phosphoserine or phosphothreonine. I'm bringing you this because drugs that we will look at will affect the production or the breakdown of these particular second messengers. And then main targets for these signal transduction pathways include transcription factors, elements of the cytoskeleton of the cell cycle components that may cause cells to grow faster or grow not as fast, enzymes, contractile elements that may cause smooth muscle to either relax or contract, ion channels, which can then affect contractile elements or cell behavior, or membrane trafficking, things that are now brought to the membrane, things that are now secreted, things like that. All of these are potential targets in cells that are activated or inhibited by these signal transduction pathways when they're activated. Now, if we look at these dose response curves, let's say you're president of Merck, the drug company Merck. You get some data and you see these 4 dose response curves. These represent 4 drug candidates. A, B, C, and D. Notice that A and B elicit their responses at lower concentrations than do C and D. So drugs A and drugs B are more potent than drugs C and drugs D. They're more potent. Potency has to do with activity at a particular concentration. The lower the concentration at which you show that activity, the more potent the drug is. It says nothing about how robust that maximum activity is. It simply refers to concentration. So A and B are more potent than C and D. So potency refers to the effective dose 50. Effective dose would be in an animal or a person. Effective concentration would be in some sort of in vitro situation in cell culture or test tubes or something like that. So the lower the ED50, the greater the potency. B is more potent than C or D. B is a partial agonist. However, D is more efficacious than B. Efficacious because it has a higher maximum effect. So efficacy refers to the maximum effect, the degree of it. Potency refers to the concentration it takes to get there. So you want high potency and you want high efficacy when you are designing drugs. Drug candidates A, C, and D, they all have the same maximum efficacy, but A is the most potent. Now, if we look at these curves and we see the slope of drug candidate D, that slope is really steep. When you get a dose response curve that is as steep as what you see in D, that suggests that that drug is way too toxic. The difference between, so if we get my arrow here, in fact, maybe if we, you see this concentration here where you get no effect at all. Then you see the concentration up here where you get your maximum effect. So essentially, and let's say you start to see the effective concentration might be here. Essentially, you only have this much concentration of the drug to work with. So if you see a dose response curve that is this slope, that drug is probably too toxic. Now, this is a quantile effect curve. Quantile dose effect curve, this is done in laboratory animals. In blue over here, you're testing the effect of the drug with respect to its physiological effect. Over here in red, you're testing toxicity of the drug. So over here, you see an ED50 right there. Over here, half your animals now are either dying or they're showing toxic effects. So this number here, this is your effective dose 50. Over here, this is your lethal dose 50. Lethal dose 50 refers to the dose of the drug at which half your lab animals die, or if the drug doesn't kill them, at which half the lab animals show toxic effects, whatever those effects are. The ratio between the lethal dose 50 and the effective dose 50 is called the therapeutic index. The therapeutic index. The bigger the therapeutic index for the drug, the safer the drug is. The lower the therapeutic index, the more dangerous the drug is. We will look at some drugs with very narrow therapeutic indices. And those drugs have to be used with a great deal of caution. Other drugs have very wide therapeutic indices and are much safer to use. All right, let me just pause right here, see if anyone has any questions.
So is the therapeutic index between ED50 and LD50?
Yes, you take the ED50, you divide it by the LD50. So LD50 is the numerator, ED50 is the denominator. So you should have a number bigger than 1. The closer it is to 1, the more dangerous the drug is.
Okay, thank you.
You're very welcome. Anything else? All right, let's soldier on. Talked about what the drug does to you. Now let's talk about what you do to the drug. This is pharmacokinetics. So with drug therapy, you have a dose of the drug that you administer, and that drug gets absorbed. Depending on the mode of administration, the drug will have varying degrees of absorption. On page 6 of your notes, your handouts, you have different ways that the drugs are administered. You have sublingual, which is under the tongue. You'll even have buccal, where you have a little strip. It's paper-ish. You take the strip and you put it essentially between your cheek and gum. That's a buccal administration. Acenapine, for example, is an antipsychotic. Acenapine comes in buccal strips that you put between your cheek and gum. There are other drugs that are administered buccally. You have drugs that are inhaled. Many of your drugs for asthma are inhaled. They're intranasal drugs. They come as nasal sprays. Intravenous drugs are given into a vein. Intravenous drugs, of course, their absorption is complete because they're going straight into the bloodstream. Subcutaneous administration, where you're pinching, essentially, the skin, and you pinch it, and that area, if you pinch your skin and that area that rides on top, underneath that, you inject into that little layer of fat underneath the dermis. Endotracheal administration through endotracheal tubes. Oral, of course, by mouth. That's the most popular way you administer drugs. Rectal, that is with a suppository. Suppositories are usually encased in wax. As the wax breaks down, the rectal area is very rich in blood vessels, not unlike the area underneath the tongue. There's also a transvaginal. There's suppositories that are administered transvaginally as well. There's transdermal. This comes as a patch. This is a very effective way to administer drugs, but not all drugs should be administered this way. There's oral drugs that are administered into the ear for ear infections. Ocular, if the drug is administered into the eye. Gastric, if you give the drug via G-tube. Intraosseous, where the drug is administered into bone. There's something called a bone gun that can be used for that. EMTs, we use bone guns to get epinephrine into elderly patients whose veins are hard to locate and insert into. And an intrathecal, where the drug is administered essentially into the cerebrospinal fluid via some sort of lumbar puncture. That gets the drug right past the blood-brain barrier. So absorption. That gives you a concentration of the drug in the systemic circulation. From there, the drug will be distributed to the tissue where it needs to work. If you have a migraine headache, the drug needs to work at the blood vessels in the brain. If you have a stomach ache, the drug needs to work in the GI tract. If you have muscle pain, it needs to go to the muscles or to the nerves that innervate the muscle. If you have pain in your big toe, the drug needs to get from the bloodstream down to your big toe, and so on and so forth. The drug then will undergo metabolism. The big gun at metabolizing drugs is the liver, although other organs also take part in drug metabolism. The GI tract, kidneys, enzymes that are found ubiquitously throughout the body can metabolize drugs to some degree. So can other organs, the brain to a minor degree, other places too. That drug metabolism makes those drugs more water soluble, and they'll be excreted either by the kidney or by the liver into the GI tract. Drugs can be excreted in sweat. Volatile drugs can be excreted through exhalation. That'll be metabolism and elimination. At the site of action, you'll have a certain drug concentration that's effective at the site of action, and you will get some sort of pharmacologic effect, a clinical response of efficacy, and you might get side effects, toxicity too, especially if the drug starts to accumulate. So this part of the diagram, the top part, that constitutes the study of pharmacokinetics. This lower part, that's pharmacodynamics. That's what the drug does. Pharmacokinetics is how your body handles the drug. So your goal with pharmaceuticals is to get the biggest therapeutic bang for your pharmacologic buck with fewest side effects as possible. That's what you're trying to do. So how does one get a dose? Doses, of course, are calculated in the clinical trials. So when you submit the investigational new drug application that allows clinical trials, you'll have a drug concentration that comes from your quantile dose effect curves. That will give you essentially guidelines that you can use. Those guidelines that you get in animals are not perfect, but they tend usually to be a good starting place. So from the animal studies, then you'll know where to start and you'll know where to go. Now, keep in mind with these clinical trials, there are lots of exclusion criteria. You'll exclude people who are pregnant. You'll exclude children. You'll exclude people with certain medical conditions. You're only going to do the phase 1 trial on young, healthy people usually. When you go to phase 2 trials, again, you're giving it to patients, but if you have complicating factors, you exclude them. So these trials are very controlled. But once you get a new drug application, you have your agreed upon formulation of the drug and the way you're manufacturing it and your dose. And that's very important. So there are some processes that specify various pharmacologic parameters. And first is clearance. Clearance refers to the rate at which the body eliminates the drug or clears the drug from the body. So how well the drug rids itself of the, how well the body rids itself of the drug. That rate is the clearance. Now on page 9 of your handouts, there are some equations that let you calculate many of these parameters we're going to look at. Clearance, you'll notice, is equal to the rate of drug elimination divided by the plasma drug concentration. So it's going to be a rate, usually milligrams, liters, milliliters, something like that, per some sort of concentration, per unit time, per kilogram body weight, something like that. That's usually what will be your units for clearance. Your volume of distribution, that's the space in the body that's occupied by the drug. That will depend on chemical factors that influence the drug's distribution, such as solubility. So aqueous soluble drugs, they'll go wherever the blood goes. They'll have a pretty wide volume of distribution, particularly if they can penetrate certain types of barriers, like the blood-brain barrier or something like that. Their drugs are more fat soluble. They will tend to be sequestered inside fatty areas in the body. So they'll have a lower volume of distribution, except as you get older and you get less lean mass in the body, now you're going to have more volume of distribution for lipid-soluble drugs. This is particularly the case for a lot of your psychopharmacologic drugs. Elderly people will tend to store them in fat stores, and so they'll depot those drugs much more than, say, a younger person. Apparent volume of distribution is the amount of the drug in the body divided by the plasma drug concentration. That will give you your apparent volume of distribution. If you look at page 5 of your handout, you have different compartments and their volumes. This set of parameters on page 5 gives you a way to estimate the volume of distribution, because you'll notice that equation that I gave you requires you to measure the drug concentration in the blood. That's a more complicated experiment. What you have here on page 5 is a, excuse the expression, quick and dirty way to estimate the volume of distribution. And as estimates go, these can be pretty effective. A word about clearance. Here's the equation we talked about before. Clearance equals the rate of elimination divided by the concentration of the drug in the plasma. However, when you're calculating clearance, clearance will be additive for every mode of clearance. So it will be renal rate of clearance plus clearance by any other mode. If it's just renally cleared, fine. You have your rate of clearance, but it'll be rate of renal clearance plus the rate of hepatic clearance plus the rate of clearance by whatever means. Skin, breath, whatever, tears, sweat. So your total clearance are all the modes of clearance that are all added together. Usually, drugs will have a primary mode of clearance that will be the big one. The others are so small relative to that primary way of clearance, you can ignore them. Others, not so. But for a lot of cases, many renally excreted drugs, for example, you can ignore the others. If your calculation is off, then you better start including those because they're probably significant. For most drugs, the rate of clearance depends on the concentration of the drug in the body. The more drug you have in the body, the faster it's cleared. That's called capacity limited clearance. That's what you see in most cases. However, there are some drugs, typically drugs that are excreted by the liver, where the clearance rate depends on the flow of blood through the liver. And it also depends upon the effectiveness of the liver in metabolizing that drug. So this is called flow limited clearance. Flow limited clearance. And this is independent of concentration. And because liver effectiveness and flow rates through the liver tend to be inherited, this is something you'll have to measure, and it'll vary from person to person. Here is a sampling of some drugs that are flow limited. Now, I want you to see some of the drugs that are on here because we're going to study some of these. So this drug is a beta blocker, and we'll look at that one. Same thing here. They all end in laughing out loud, LOL. These two drugs are flow limited. Propranolol is also used for migraine headaches. Verapamil is a calcium channel blocker. That's also flow limited. These three drugs here, pentazocine, morphine, and meperidine, those are opioids. Their clearance is largely flow limited. So is lidocaine, which is a topical antibiotic. These two drugs here and this one here, these are tricyclic antidepressants. They're not used so much anymore. Now with the SSRIs, they've replaced the use of these, but if SSRIs don't work, TCAs then will be used. And these two TCAs tend to be flow limited. Isoniazid is a anti-tuberculosis drug. So these are some examples of drugs that are, whose clearance is flow limited. They're not dependent on concentration. So volume of distribution, that's the way you calculate it, but as we said, start using the table on page 5, you can estimate it. And this leads us to the drug half-life. The drug half-life. The drug life is the amount of time from the initial dosing of the drug that it takes for the concentration of the drug in the body. Let me rephrase that. For the peak concentration of the drug in the body to be reduced by half. It's the time, starting at the time of initial dosing, that it takes for the peak concentration of the drug in the body to be reduced by half. That's the drug half-life. Some drugs we will examine have very long half-lives. Others will have very short half-lives, and may require multiple doses during the day. There's an effective way to calculate the drug half-life. It's 0.7, or if you really want to get persnickety, 0.693 times the volume of distribution divided by the rate of clearance. So the more effectively the drug is cleared, usually, as you can see, the bigger that number is, the lower the half-life will be. The smaller that number is, the bigger the half-life will be. Let's illustrate drug half-life in this way. So let's say someone comes into the clinic and you hook them up to a IV and they have a rate of drug that's being given to them. That rate of drug administration will cause the drug to accumulate. However, at a certain point, the rate of accumulation will equal the rate of clearance. So this is a so-called steady state of the drug. What happens if we turn the pump off so that the patient now is not getting any more drug? What will happen to this concentration? This will happen. So here's the elimination of the drug after a constant rate infusion of a drug and after it reaches steady state, and then you stop it. You get this, once again, asymptotic reduction in the concentration of the drug. Notice there's a point at which these two graphs overlap. That point is the drug half-life. And that, in fact, clinically is how you measure the half-life. All right, we will come back to this on Friday. Don't forget Friday, we have a quiz. We'll do that first, then we'll get into this, and we'll be in the classroom on Friday. I thank you all for attending, and here's what's going to happen. I will hang out for a bit after I stop the slides. If you have any questions, please hang out and ask them. Otherwise, you can simply sign off. And again, I thank you for your attention and hope you get a chance to go out and get some fresh air on this snowy day and maybe have a snowball fight with someone. All right. Good day to you all. And again, I will hang here if anyone has any questions.
Okay, something we